Look, we're 1 minute past 1:30. Hi, everyone. Thank you so much for joining. I'm Shivani Misra. I'm a consultant in metabolic medicine. And to my right on my screen is Professor Trisha Tan. And together with Wei Yang, who's in the corner on my screen, and Mariana Abdel Malik, our two registrars, we've put together this training program. And actually, I'm going to hand over to Julia very shortly to do the diabetes cases. But before that, I wanted to just take advantage of the audience and tell you a little bit about metabolic medicine, because some of you might not know what metabolic medicine is. And for those of you who haven't committed to a particular specialty, Wei, can you put that slide up, please? You might be interested to know that the applications for metabolic medicine at ST3 level are currently open. So metabolic medicine, if my slide comes up, is basically a specialty. And you can see on the right-hand side here, it's a specialty that combines clinical biochemistry with research and 5 key clinical areas, which I've written there in blue: obesity, the management of dyslipidemia, diabetes, nutrition from an inpatient perspective, and also adult inborn errors of metabolism. But I've also put another box there because I'm sure our registrars will agree, and certainly I thought so, and I'm sure Trisha will agree, that there are actually lots of opportunity to pursue different areas of interest throughout your clinical training within the remit of biochemistry, through research and through audit. So this is actually a really wonderful specialty. Obviously, I'm biased, but if you are interested and you've got MRCP and you're potentially research focused, this might be the specialty for you. And unlike other laboratory-based specialties, for example, histopath, we're actually very patient facing. So both Trisha, myself, and the other consultants, we all have our own clinics and we're seeing patients almost daily. So that's just to whet your appetite. As I said, the applications are open. It's a group 2 specialty for people currently applying. So you can apply if you're an IMT2. And the application's open just a few days ago. If I've piqued your interest, please take a note of those email addresses. There's Trisha, myself, and Jamie, who's speaking after Julia. We'd love to hear from you. Even if you're at an earlier stage, please get in touch with us, because we advertise periodically, and we'd love to sort of coach you and nurture you through that application. So that's just a bit of a hard sell, and we'll put this slide up again in the breaks. But I'm now going to hand over to Julia Kencree, who's a senior registrar in metabolic medicine and also an NIHR clinical fellow with an interest in bariatric surgery and diabetes remission. And she's put together some really lovely cases which will hopefully you will think that they are relevant and interesting on diabetes. So thank you very much, Julia.
Hello all, really nice to be able to speak to you today. So as Shivani said, I'm Julia Kencree. I'm working within the Northwest London scheme as a metabolic medicine registrar and also as an NIHR clinical fellow. And I'm going to start off today going through some interactive diabetes cases. And these cases are written by Dr. Shivani Misra, so many thanks indeed to her. For the interactive part of things, we'll be using Mentimeter. So this is the website and the code that we will be using. So if you could just log in now using that code, and I'll remind you of it periodically. And if you have any questions as we go along, could you please use the chat? If I don't see the questions immediately, then I'll come back to it at the end, or if there's not enough time to answer during the talk, I'll always answer it in the chat afterwards, okay? Lovely. So let's start with a case. This is a 45-year-old gentleman. He's not been feeling well for the last month. He's thirsty, he's losing weight, he's polyuric, and the only tests you have are a urine dipstick glucose, which says +++. And the question that I have for you, an interactive question, is does this man have a confirmed diagnosis of diabetes? So if you could log into menti.com and enter that code, then we should be able to see what you think. So I'll just stop sharing and switch my my screen. So does this man have a confirmed diagnosis of diabetes? I'll hide the results so far to see, so you can all have a chance without kind of seeing what others have said. And we'll just, this is a quick one just to get you warmed up. So we'll do a lesser countdown, actually not a whole minute. So, okay, let's have a look and see. 14 people have participated in this. Get yourself logged in and participate if you can. And most people think that no, this man does not have a confirmed diagnosis of diabetes at this point. Okay, so that's fine. So we'll talk about that just in 1 minute. Let's see if we can go back to the presentation. Okay, so we don't think this man has a confirmed diagnosis of diabetes at this point. So now I'm going to progress the case for you a little bit further. This man now has a random plasma glucose of 22. HbA1c is 45 millimoles per mole. And does this man now have a confirmed diagnosis of diabetes? So we will just going to share my screen and progress to the next case. So does this man now have a diagnosis of diabetes? So just to remind you, he had symptoms of polyuria, weight loss and thirst, a urine dipstick that was positive for glucose, a random plasma glucose of 22, and a HbA1c of 45. I'm just going to give you 10 more seconds just to have a go at that question, just to sort of wake everybody up after lunch. And then we'll have a look at the results. Okay, lovely. I'm just going to stop it there. So 12 of you think yes, 3 of you think no. So the answer here is yes. He's a symptomatic patient with a random plasma glucose of above 11.1 millimoles per litre. So he does have a diagnosis of diabetes. And the key point here is that in terms of diagnosis of diabetes, there's a few ways that we are allowed to do it according to the WHO criteria in 2006 and 2011. A fasting plasma glucose greater or equal to 7, an OGTT with 75 grams of anhydrous glucose, so a 2-hour level greater or equal to 11.1, and in a symptomatic patient, a random glucose of greater or equal to 11.1, and a venous blood lab HbA1c of greater or equal to 48 millimoles per mole. And the 2 key points I wanted to make here really was we can't use a urine dipstick, and we don't recommend the use of a capillary blood glucose at this point. And the reason these endpoints were chosen by the WHO are based on microvascular endpoints, particularly retinopathy, and how they match with these particular diagnostic criteria. Okay, so based on that, based on the things that we know could be used to diagnose diabetes, which test do you think is the best to diagnose type 2 diabetes? So we'll go again to Mentimeter and see what you think. So here we could have a 2-hour 75-gram OGTT, a HbA1c, a fasting plasma glucose, or a random plasma glucose, as we had in our case. So we had a HbA1c and a random plasma glucose. Which test do you think is the best one to diagnose type 2 diabetes? Okay. We'll have a look at the results here. So yes, most of you think HbA1c at this point. A few of you have said OGTT. Nobody thinks fasting plasma glucose or random plasma glucose in the patient with type 2 diabetes. So the next question following on from this is which is best to diagnose type 1 diabetes? Does that differ when you're diagnosing type 1 or type 2 diabetes? So again, I've got exactly the same options that you had for type 2 diabetes, but this time we're asking you what is the best test to diagnose type 1 diabetes. So is it again OGTT, HbA1c, fasting plasma glucose, or random plasma glucose? Okay, I'm just going to give you 5 more seconds just to have a think about that, and then we'll have a look at the results. Okay, so there's a bit more of a split here. We've got a lot of people liking fasting plasma glucose in a type 1 diabetic, or a patient with type 1 diabetes, sorry. A random plasma glucose has been suggested by some. Some people have suggested you should use an OGTT, and one person has suggested HbA1c. So I think the main point I wanted to bring out from this question, and I'm just going to go back to my slides and show you, is that actually with a patient with type 1 diabetes, we would not use HbA1c, and it should not be used to diagnose type 1 diabetes. It was introduced in 2011 to the diagnostic criteria for type 2 diabetes, but we don't use it for patients with type 1 diabetes. The other thing to think about is when we think back to the case 1 that I presented with the gentleman with a HbA1c of 45 and a random plasma glucose of 22, is you can see there can be discordance between the criteria. So one would meet the diagnostic criteria for diabetes, whereas the other wouldn't. And so we're going to talk a little bit about that now. So the other point I wanted to make before we move on is that when thinking about the best test and the best test to diagnose type 2 diabetes, we need to know about the stages of development of type 2 diabetes. And here we've got the glucose levels that you would expect within the so-called normal population with a fasting level less than or equal to 6. And the fasting plasma glucose in a patient with type 2 diabetes, remember, is greater or equal to 7. The other way we can test is using a 2-hour oral glucose tolerance test. And again, I've given you the levels here. Usually, the oral glucose tolerance test, the increase at the 2-hour level occurs earlier or prior to the impact on the fasting glucose levels. That's not always the case, but more commonly you would see a level a rise in the oral glucose tolerance test as opposed to the fasting. And then of course we could use HbA1c as a diagnostic criteria. And what we want to think about is what's actually happening pathophysiologically. So thinking about the insulin, normally under normal circumstances, when you have a normal fasting plasma glucose, HbA1c and 2-hour OGTT result, the pancreatic beta cells are working and there's not an excess demand. But what is happening with type 2 diabetes, of course, is that you are getting an increase in insulin resistance. And initially the pancreatic beta cells respond by increasing their output to meet the needs of the tissue, which is what's happening in this section here. And then what happens at the diagnosis of type 2 diabetes, which you'll probably see a little bit better on the next slide, is that actually the beta cells can no longer adequately respond to the demands that of insulin. And really what you can see here, and the important point that I wanted to make from this slide, is that actually by the time you're diagnosed with type 2 diabetes, actually there's a significant reduction in beta cell function by this point actually. So the beta cell function would normally have been declining for 10 to 12 years before you are diagnosed with diabetes, so that you can have discordance and abnormalities within these tests in that period of time beforehand. So to answer the question, or to not answer the two questions that I posed to you, really, is there a best test? Well, there isn't a best test. They all of these tests identify different subsets of people with diabetes at different time points in their disease. And often early on, when patients diagnose diabetes, there may be incomplete overlap, so that there may be one criteria that's met and another that isn't. And so what you need to consider when you are using a diagnostic test for your patients with diabetes is all of these things. So biological variability, which we know, for example, is very wide for fasting plasma glucose. Sample stability, for example, HbA1c has excellent sample stability. We can keep it sometimes for up to a week and still test HbA1c on a sample, versus a glucose, which we know we cannot do that because glycolysis will be ongoing. Cost, convenience, how we have to prepare our patients. So for example, do we all make sure that 3 days prior to their OGT that they get at least 150 grams of carbohydrate for the 3 hours, for the 3 days beforehand, that they always have their OGT at 7 to 9 a.m. in the morning? So there are certain standardized things that need to be prepared for the patient depending on what test you're doing. Potential interference, I'm particularly thinking here about HbA1c, and we may briefly discuss that. The type of diabetes, again, we talked about that HbA1c is not appropriate in patients with type 1 diabetes, and the age of the patient. So then just to briefly talk about the 2011 WHO guidance, this suggested that HbA1c can be used for the diagnosis of type 2 diabetes. And the advantages really here are that you don't have to do any specific preparation for the patient, so it's a lot more convenient for them, and there's much less biological variability than perhaps you would see in a fasting plasma glucose or an OGTT. However, it's more expensive, and it's only a surrogate marker. It's not measuring actual glucose, and it can be susceptible to interferences. And I've just put this extra reference for you, which basically is the National Glycohemoglobin Standardization Project. And this goes through in much more detail the interferences when you're testing and measuring HbA1c. So you can refer to that if you want to find out a little bit more about this. Okay, so the take-home message really from the last few slides are that avoid, if you can, mixing testing modalities, because glucose and HbA1c measure different things. Fasting glucose, for example, is after an overnight fast of at least 8 hours, and it can be impacted by how much your patient has exercised, how you handle the glucose sample. So we know that glycolysis, even in a tube with an additive in, is going to continue for 4 hours after taking the sample, the meal type the patient's had beforehand. And then in terms of HbA1c, we need to think about glucose exposure. I'm particularly thinking about the first case that we talked about, a patient maybe early onset in their type 1, in the diagnosis of type 1 diabetes, that the red cell may not have had a long period exposed, and so the HbA1c may not be diagnostic at this point. And also we need to think about red cell turnover. So it's not surprising that actually in our case we had a random plasma glucose of 22 and a HbA1c not diagnostic, because discordance can happen when we're diagnosing diabetes. So it's best, if possible, not to mix modalities when you're testing. Okay, so let's build on that and think about HbA1c now. So this next case is a 56-year-old man with type 2 diabetes. He's got a HbA1c this time of only 18 millimoles per mole. He was diagnosed with diabetes a year ago, treated with metformin and gliclazide. And when he was when he last had his HbA1c measured, it was 60 millimoles per mole. So he's had a significant reduction in his HbA1c. And his BMI is 24 kilograms per meter squared, and is referred to diabetes clinic. So let me just ask you another question here. So 1 second, let me just switch my screen. Okay, so why do you think this patient has had such a dramatic reduction in their HbA1c? They could have excellent control. Have we pushed the diabetes into remission? Or does this patient have a falsely low HbA1c? So if you could just put what you think, and we'll work through the case a little bit further. I know I haven't given you all the clinical details, so we'll go through those together a little bit as we go along. So actually, you've all gone for falsely low HbA1c, because otherwise, why am I presenting this case? So I think that's savvy. So let's have a look and see what this case is about. So this patient was referred to diabetes clinic, and the clinical history is incredibly important here. So he'd not been feeling very well. He was thirsty and polyuric, and actually his GP surgery was surprised when they got a HbA1c of only 18, and they very sensibly tested a random glucose on this patient, which was 15 millimoles per mole. So again, this is all about discordance between what our glucose is saying and what our HbA1c is saying. The other clinical history from this patient was they had been recently referred to dermatology for a rash, and at that point he was diagnosed with dermatitis herpetiformis, so of course a skin manifestation of celiac disease, and started on dapsone. So actually, when he was referred to clinic, he had continuous glucose monitoring, and this is the results for, I think it's a sort of 5 to 7 day period. And obviously on the x-axis here is the time, and on the y-axis is the glucose measurement. And obviously he's not at all in where we would want him to be, which is between these green bars. He's in fact running at least 10 millimoles per litre, if not above that, which would not be consistent with a HbA1c of 18. So everybody who said falsely low HbA1c is correct. And actually, on further testing, this patient had raised reticulocytes. He had, and an anemia, and actually he was probably hemolyzing on dapsone. So he's got an increased fraction of young erythrocytes, and therefore his HbA1c is simply not reflecting his average glucose measurement over 120 days. And so the important point from this case really is that there are caveats surrounding the use of HbA1c, and if it doesn't match the clinical picture, you need to consider alternate testing. Here, we've just listed a few things that can cause a falsely low HbA1c, so drugs, hemolytic anemia, all of these things that may affect the survival of the red cell. But of course, there are other things, for example, that we haven't put on here, for example, liver disease. So if the HbA1c does not match the clinical history of the patient, then we need to consider alternative methods of testing. And actually, leading nicely onto the next case, this is a 56-year-old man who was diagnosed with type 2 diabetes, but in fact, this patient decompensated and needed insulin within a year of diagnosis. He's also got another autoimmune condition, celiac disease. And so actually this patient was reclassified as adult onset type 1 diabetes. Okay, so this is a bit of a quick fire round that I've got for you. And this really is just thinking about the classification. So now moving on from just HbA1c and glucose, we're now moving on to think about, is this type 1 diabetes? Is this type 2 diabetes? Or is this something else? And so I'm just going to put Mentimeter back on again. And this is just a very quick sort of 5 seconds first gut feeling of, if you had a patient with these clinical details, what would your gut feeling be in terms of type of diabetes? So I'll just switch screens for you now. Okay, so 24-year-old, feeling thirsty, tired, BMI of 26, random glucose of 22. So kind of gut feeling of what you think, is this type 1 diabetes, is this type 2 diabetes, or is this something else going on here? So we've got 15 of you, you were quick, you took the quick fire to heart. So I better see that. Okay, so most of you, interestingly, most of you think this is a patient with type 1 diabetes, presumably because they are young, they haven't got a very high BMI, or it might be a bit higher than we might sometimes see, and they've got a very high random glucose. Okay, so now the next case for you this is again a 24-year-old, so same age, but what we've changed here is that they're feeling thirsty and their BMI is 36. Again, their random glucose is 22. So what's your kind of gut feeling when you see that kind of patient as to what initially you think their diagnosis is? Okay, so you're quick again, quick off the mark, quicker than me. Let's go. Let's see what you've got. Okay, so most of you here, again, presumably because of the BMI of 36, you'd initially think this patient is more likely to have type 2 diabetes. Okay, and then the final case that I want you to give your feedback on is this time we've changed the age. So they're 54, they're feeling tired, thirsty, so they're symptomatic again. Their BMI is 26 this time, and their glucose is 22. So just again, initial thoughts, what your initial thoughts would be when you were diagnosing what type of diabetes they have. Okay, so again, I'll hide. Again, so this one, there's a little bit of a mixture. So there's some possibility of an other diagnosis here. More of you think type 2 diabetes, because although their BMI is 26, they're 54, so they're a bit older, so that may push you more towards type 2 diabetes. Okay, thank you very much for contributing there. So let's go back to our presentation and see. So those are our patients. Now I want you to think, I haven't done a sort of poll on this one, just because I didn't want to overwhelm you with too many polls. But now if we change the picture slightly and we ask this question, so instead of just being a 24-year-old with a BMI of 26 and a random glucose of 22, does it change your mind about what you would have chosen? Most of you chose a patient with type 1 diabetes that I now say they're South Asian. Does that change the type of diabetes you would have chosen? And again, the second case is now, we've added ethnicity here, they're African Caribbean, and then the third patient is Middle Eastern. So does ethnicity impact how you would have classified your patients with diabetes? And the real point I wanted to make from these cases is that we all do this. We all use age, BMI, and ethnicity to help us determine what type of diabetes a patient has. And the point is not that we should not use these clinical factors, because in fact, a systematic review sort of relatively recently, a few years ago, found that age at diagnosis and BMI were the only evidence-based features at diagnosis that robustly discriminated type 1 from type 2 diabetes, with age being the most discriminatory. But actually, it's not always right. And it's important to question ourselves when we make these assumptions. And so, yes, if we're thinking of a textbook or a simple vignette, we may be able to easily classify, but in real life, that's very different. So we know that with an increasing BMI and increasing age, most of our patients will have type 2 diabetes at diagnosis, and our young, slim patients are more likely to have type 1 diabetes. But of course, there is a continuum such that older patients can also be diagnosed with type 2 and type 1, and again, younger patients, and in fact, we know this, that there is increasing numbers of patients with type 2 being diagnosed in adolescence and childhood. And then, of course, we've got the other things that we need to think about. We've got lean people with type 2 diabetes. We've got adults with type 1 diabetes. So whilst we can use them easily to discriminate, to help us discriminate between type 1 and type 2, they are not hard and fast rules. And so the important points for the quickfire round was really just to remind you to pay attention to the history. If in doubt, insulin is always a safe treatment. And then be reflective. So for example, we saw that case of the patient reclassified, and he was an older patient with type 1 diabetes. So if the clinical course doesn't fit with your initial diagnosis, re-review, and then you can consider specialist tests. And that's where I want to just spend a little bit of time talking to you now about specialist tests. Now, NICE doesn't suggest that we use specialist tests routinely with our patients to diagnose type 1 diabetes. So if it's very clear clinically, then they do not suggest we routinely use specialist tests such as C-peptide and pancreatic autoantibodies. I can talk a little bit about C-peptide, but actually the focus of this, I'm just going to talk a little bit about pancreatic autoantibodies because it's probably something we talk less about. So from a NICE perspective, what they suggest is that if your patient has type 1 diabetes, but with atypical features, so they're aged over 50, or they've got a BMI of over 25, or they've got this slow prodrome, then you might want to consider using C-peptide and autoantibodies. If there's a clinical suspicion of monogenic diabetes, C-peptide may be very helpful, or autoantibodies may guide genetic testing. And then the third place where you may use this is if the classification is uncertain. So of course, if you can diagnose a patient with type 1 diabetes, that may change your management and also give them access to treatments that are not necessarily available for patients with type 2, such as pump therapy. So to talk about the pancreatic autoantibodies themselves, they form against components of the beta cell, which you can see here. And there are several autoantibodies that have been detected. So here I've just listed the top 3 that are commonly, more commonly tested, which are glutamate decarboxylase 65, GAD65, islet antigen 2, and zinc transporter 8. And there's also been other sort of newer antibodies that are tested, but not so commonly in routine clinical practice. And I just wanted to sort of just talk you through or guide you through the caveats that you need to think about when you're using these in testing. So they're very helpful in that they can confirm a suspicion of type 1 diabetes, but the important caveat here is that negative antibodies don't say that a patient does not have type 1 diabetes, because 20% of patients with type 1 are actually antibody negative. So let's think about what things we need to think about when we are using these in our clinical practice. So the first thing we already talked about, which was that if they're negative, it doesn't exclude that a patient has type 1 diabetes. And in fact, we know that they're most useful to measure early on because they're more likely to be positive, and titers diminish with duration. However, GAD65 and IA2 antibodies are likely to stay positive for many years, making them useful even long after the diagnosis, even if the titers do diminish. It's thought that some ethnic groups may have lower rates of positivity than others, so that's something to consider when you're testing. Less than complete testing just means knowing what you're testing and what your lab does. So sometimes a lab may only do one autoantibody, and we know that, for example, from a study that was done, 60% of patients with type 1 diabetes were positive for GAD antibodies, but when you included GAD plus or minus IA2, that increased to 80%. So if we've only got a single antibody positivity, or single antibody, tested, then that may be less helpful in our diagnosis. The fifth thing we need to think about when we're testing autoantibodies is some people without diabetes are antibody positive. So there's a background positivity of up to 4.7% of the population. So what does that actually mean in terms, what will that mean for the future for that patient? And what does that mean in terms of if they were then to go on to develop diabetes? And then there's this, and again, this is talking about significance of antibody positivity. If you've got a single autoantibody positive, the others are negative, what does that mean? So there are several challenges of interpreting pancreatic autoantibodies, but they can be useful in an adjunct when you're defining the difference between or trying to decide whether your patient has type 1 or type 2 diabetes. I'm not going to specifically talk about C-peptide here, but again, there are several instances where that may be useful. And the only point I wanted to make about C-peptide and C-peptide testing, which is of course that one, there are no well-defined cutoffs. You can use the cutoff of less than 200 picomoles per liter is helpful as long as a patient's glucose is above 8. But apart from that, there are no well-defined cutoffs for C-peptide. So that's the only point I wanted to make. Okay, so now for our final case, we're going to talk about the other. So this is a 25-year-old lady, her mother has type 1 diabetes, and she used her mother's glucose monitor and checked her blood glucose for fun. And actually, she had a random capillary blood glucose of 15 millimoles per litre. And we remember from our beginning of our lecture that actually that would not be diagnostic of diabetes, because we don't use capillary blood glucose to diagnose diabetes. Her BMI was 21, so she was slim, and she did not have any symptoms suggestive of diabetes. And her GP very sensibly went on to do a fasting glucose, which was in the range of diabetes. So it was 8.9 millimoles per litre. So this patient had an older sister who'd been diagnosed with diabetes when she was 16, and her maternal grandfather had type 2 diabetes age 30, and he was taking tablets. And another aunt had an unknown type of diabetes. And here is the family history. So actually, this patient, this is the patient. This is our kind of in our case, and this is her family tree. So you can see her mother has type 1 diabetes, her father has her mother's sister, has type 2 diabetes, and her maternal grandmother has type 1 diabetes as well. So she's got flags that make us think there may be something else going on here. And she's got multiple generations in which they have early onset of diabetes. And actually, it's not that all the generations have been treated with insulin and are known to have type 1 diabetes. If you remember, there were some patients who'd been on tablets were treated. And so actually, this is a classical history for MODY. So this is maturity onset diabetes of the young. And as you know, these are single gene defects causing diabetes. And depending on the genetic diagnosis will depend on what is the best or the precision medicine treatment that you should be getting. And this patient had HNF1 alpha MODY, which is the most common type. And just the key points I wanted to bring home about this, the diagnosis of MODY, are that actually in patients under 30, we think it accounts for about 1 to 4% of diagnosis, but it's really underdiagnosed. And the reasons for this are that there's a lot of clinical overlap. So most patients don't present necessarily in this classical way with very slim, multiple generations that are very clearly defined. Actually, there's a lot of clinical overlap. It's not always as easy to diagnose. It may be that there's a reluctance among the medical professionals to reclassify a diagnosis of diabetes. And obviously, of course, not all patients with MODY are going to have a sort of family history, because it may be a de novo mutation. And so these are the collection of genes that cause MODY, or the major ones that cause MODY. And this was our patient. So she had a HNF1 alpha mutation, which is a transcription factor within the beta cell. And it's a transcription factor that normally stimulates insulin production. And so insulin production with this mutation is reduced. And actually, the important point for patients with both HNF1 alpha and HNF4 alpha is that they can be treated with low dose once daily sulfonylurea, as opposed to insulin or other treatments that may be used. The reason that it's important to diagnose patients with MODY is because it impacts the treatment that they can have. For example, for patients who are diagnosed with HNF1 beta, they will need insulin and pancreatic enzyme replacement therapy. So it's an important diagnosis to think of. So in summary, from today's cases, I just wanted you to take home a few important points that the modalities or the way that you diagnose diabetes might not overlap. So it's important to consider why that might be, and to try and pick one modality and the best for your patient. That their changes in HbA1c may not be just related to the average glucose within the blood. It may be related to red cell turnover. That differentiating between type 1 and type 2 diabetes can be challenging. There are extra tests we can do, including pancreatic autoantibodies and C-peptide. And actually, this website here from Exeter has a really excellent, easy to use resource for both diagnosing differences between type 1 and type 2 diabetes, but when we also may consider MODIs. They also have a calculator for helping us decide whether MODI is a likely diagnosis.
Okay, I will introduce the next speaker. The next speaker is Dr. Jamie Siegler, who's our consultant in metabolic medicine, who leads the lipid service. And Jay's going to talk to us today about novel treatments in lipidology.
Hi, Trisha. Okay, so hi everyone. As Trisha mentioned, I look after the lipid service at Hammersmith Hospital, and so I'm coming to this talk very much as a clinician looking after lots of patients with lipid disorders. And also we run quite a few clinical trials of various agents for lipid lowering. So we'll be talking about quite a few of these along this talk as well. So just to put this in context, so 2019, Public Health England were asked to come up with a long-term plan for cardiovascular disease. And for the first time, cholesterol was part of this long-term plan, and they decided to go for this ABC approach. They have AF, atrial fibrillation, high blood pressure, and high cholesterol as the three major causes of cardiovascular disease, and the main focus for the next 5 to 10 years of Public Health England in terms of cardiovascular disease ambitions. And so this was really, really exciting for people in the lipid field, because cholesterol for probably, forever really has been a bit of a Cinderella condition within cardiovascular risk factors. So it hasn't been part of QOF, and is now slowly being, in the next year or so, will be part of the QOF points for GPs. And so hopefully this is going to help us really give a focus to managing cholesterol within our patients, because we know that it's a significant risk factor, and 30% of cardiac events appear to be related to untreated or inadequately treated cholesterol levels. So the format of this talk, we've got half an hour, and I'm going to go through just cardiovascular risk in general and lipid lowering in the general population. And then we'll focus specifically on lipid lowering therapies, and we'll talk about treatments that we've got currently available to us now, the standard ones that you're probably quite well aware of, newish ones, and then the new ones on the block. And then I'll finish off just showing you the national pathway that we have devised for cholesterol management. So let's start off with CVD risk and general population risk management. So we'll do this case. So we've got a 59-year-old plumber. He's completely asymptomatic, no family history of cardiovascular disease, and he's gone to the GP for some routine blood testing and has been found to have this lipid profile. So let's just look at this in a little bit of detail. So we've got a total cholesterol of 7.2, a HDL of 1.4 millimoles per litre, LDL cholesterol, which is obviously calculated by the Friedewald equation, of 4.1, triglycerides of 1.4, and then at the bottom of this profile, we've got this non-HDL cholesterol as well. So normally, if we were in a live audience, I'd ask you what you thought of this, but I think, I think we'd all agree that, this total cholesterol looks a little bit on the high side. If we looked at the median cholesterol, total cholesterol in a population, for a 59-year-old male, we'd expect it to be between 5 and 6, probably nearer 5. So, the LDL also looks a bit high. That HDL looks nice and healthy, and the trigs are pretty normal. Our reference range is less than 1.7 millimoles per litre. And then we've got this non-HDL. So what does this non-HDL mean? What it means is all the cholesterol, your total cholesterol, minus your HDL cholesterol. And so it tells us about the cholesterol that's captured in all of these lipoproteins. So remember that, you know, most of your cholesterol is transported around the blood in lipoproteins. And we know that each of these in their own right is atherogenic. And they have one thing in common. They're all ApoB containing lipoproteins. But because they're all atherogenic, there have been lots of epidemiological studies done, and they show time and time again that your non-HDL cholesterol is superior as a biomarker of cardiovascular risk compared to LDL cholesterol, total cholesterol, or your ratio of total to HDL. So it trumps the rest of them, and that's why in 2014, NICE put non-HDL cholesterol as the preferred biomarker of choice in terms of looking at cholesterol conferred risk. We know that ApoB, if we were able to measure in a standardized way and it was much more readily available, trumps even non-HDL cholesterol. That's a different story, and that is, you know, we're not quite there yet with ApoB, but you know, I think look at ApoB and maybe in 5-10 years time, that's the way we'll be moving, but we're not quite there yet. So so really, non-HDL cholesterol is the way that things are moving, and that's what NICE have adopted in terms of our measuring cardiovascular risk conferred by cholesterol. So on the basis of this, does this guy need a statin? And the question, it's a bit of a cheeky question, because actually I probably haven't given you enough information, because really what you need to do is not just look at the cholesterol levels in their just on their own. What you need to do is work out his overall cardiovascular risk. And the way we do that is we use Q risk. And you can plug the numbers in, and GPs are doing this all the time, all up and down the country, working out people's cardiovascular risk over the next 10 years. And on the basis of that, if you've got a risk of 10 or greater over the next 10 years of developing CVD, then we offer atorvastatin 20 milligrams for primary prevention. Now, obviously, we need to rule out secondary causes of hypercholesterolemia, and the big suspects here are certain drugs, specifically certain immunosuppressants, some of the HIV drugs, hypothyroidism, nephrotic syndrome, and anorexia. And we shouldn't be using this tool in patients who are secondary prevention or have type 1 diabetes, have CKD, or have familial hypercholesterolemia, because obviously we'll underestimate their risk.
Jay, just somebody's got their hand up. Colleen.
Oh, okay. Oh yes, Colleen. Colleen, do you want to answer a question? Yeah, let's do it. Go on.
I'm so sorry, that was an error. Sorry for that.
Oh, it was a twitch. Sorry.
It must have been. Sorry, I wasn't aware of that.
No worries. We can. Why don't we? If you have questions, I'm more than happy to sort of go through them as we go along, or we can just go through them at the end. Yeah. Okay. So we've plugged his numbers in, and this is how we do it. So this is what it looks like. So when the GPs do this, you've got your date of birth, you've got male or female, ethnicity, BMI, affluence is in there, smoking, total cholesterol and HDL, so you can work out the non-HDL, blood pressure, and then several other risk factors here. And that comes out with your heart age. So it tells us that this 59-year-old plumber actually has a heart age of 66. And when we work out his 10-year risk, it comes up as 11%. So he's just above that threshold. And we can work out, if we give him that 20 milligrams of atorvastatin, we reduce his total cholesterol by about 40%. So we can work out that we would get it down to 4.1. And if we do that, we reduce his heart attack stroke risk to 6.4%. So it's quite useful for patients to see this, and I think it's quite powerful for them to, and to help them make that decision, because obviously we're talking about a tablet potentially for the rest of their lives. So what targets should we be thinking about in terms of their lipids? Well, NICE don't give us a specific number we should be aiming for, and if you remember, NICE are very much their evidence is very much clinical trial based, and it's based on certain drugs showing a certain percentage reduction and whether or not that equates to risk reduction. And so they have gone with this 40% reduction aim in non-HDL cholesterol. So that's what patients should be aiming for. In practice, this is really not liked by doctors or patients, because GPs often find that, you know, they're scrambling to find that baseline level. You know, if patients have moved surgeries, etc., they haven't got an off treatment cholesterol level for their patients, so they don't know what they should be aiming for that 40%. And patients often want to know what they're, you know, they want a target, they want an actual number. So the Joint British Societies for the Prevention of Cardiovascular Disease have gone a little bit further and given us a target, a non-HDL target of less than 2.5 millimoles per litre, which is broadly equivalent of an LDL cholesterol of less than 1.8. And we'll go through next slide where this comes from. So there have been quite a few studies over the years that have used intravascular ultrasound. So they do a coronary angiogram, they go into the coronaries and use ultrasound to quantify the atheroma within the coronary arteries. And they found that when you get to a threshold LDL cholesterol of around 1.8, that's when you start getting regression of atheroma within the coronary arteries. Higher than this, you get progression. So that's where this 1.8 millimoles per litre of LDL cholesterol has come from. And that's, you see that in all the guidelines kind of worldwide, looking at the American guidelines or the European ones as well. So 1.8 is very much a target that is used. And I believe that NICE are going to be reviewing it over the next year to get rid of this idea of just the 40% reduction and think about a more absolute target. So just to summarize that case, we should be using Q-risk to estimate CV event risk. If the risk is greater than 10%, our first off treatment is atorvastatin 20 milligrams once a day. We should be aiming for a non-HDL cholesterol of less than 2.5 millimoles per litre in our patients. So that's just a little bit about how we approach CVD risk in general. I'm now going to spend some time talking about the lipid-lowering therapies that we have available to us. So I've tried to summarize this. I know this looks complicated, but I have tried to summarize the various treatments that we have available to us. And so the one that you're all going to be very, very aware of is the statins. You all right, Julia?
There's another raised hand. I'm just.
Is there? Oh, okay, go for it, Rabia.
Hello, hi. I'm one of the chemical pathology trainees in Edinburgh, and I do lipid clinic quite, regularly. And
yeah,
thanks for talking. It's really, really interesting, very helpful. But there's one thing I want to ask you, about this in primary prevention. Obviously, we want to find out the familial hypercholesterolemia as well as I want to know whether the patient has or not. And the criteria which we have is like the NICE is, the cutoff for total cholesterol and LDL
yes.
of 4.9 and for total cholesterol.
Yes.
How does that then bring the non-HDL into is that not for the familial then? It's just like.
Yeah, no, I think you raise a really important point. And this is where NICE have, I believe, really messed up, because we have one guideline for the general population, which is very much non-HDL cholesterol focused. And then we've got a separate guideline for familial hypercholesterolemia, which is all about LDL cholesterol. And then on top of that, you've got different technology appraisals for some of the drugs that I'm going to be talking about now, which are all, again, based on LDL cholesterol. So it's not been very helpful, and it's been utterly confusing, I think, for GPs and clinicians generally about what they should be doing. And I'm sure if you look at lipid clinics around the country, there is a big mixture of what they're using. So yeah, I agree. I mean, in terms of from our lab, we offer both the non-HDL and the LDL cholesterol, and we elected to keep the LDL cholesterol in there because of familial hypercholesterolemia, and particularly in terms of the targets and things that you require. You need LDL cholesterol for as thresholds for certain drug treatments. Yeah, does that answer your question?
Yeah, indeed. Yeah, and as you talk about the guidelines, we have Dutch lipid and we have Wales and all these sort of, so it's kind of because I think most of them, they all use the LDL still. So
yes,
yeah,
Yeah. So and you know, if you look across the globe, the Americans are very much still LDL cholesterol focused, even in general population. Whereas Europe, if you look at the ESC guide, the European Society of Cardiology guidelines, they are, you know, they always give both, so the LDL and the non-HDL. So it was quite radical, actually, of NICE in 2014 to go with the non-HDL. And, you know, one could argue either way, but that's a whole different discussion. So if we've got time at the end, we can discuss that further. Okay.
That's right. Thank you.
No worries. So I'm going to just briefly go through this because it looks complicated, but I just wanted to just illustrate the main mechanisms of action of the drugs that we have available to us currently. So in this red box, you can see the statins. Okay, and as I'm sure most of you are aware, we're looking here at the liver within a hepatocyte, and statins work here on HMG-CoA reductase to reduce intrahepatic cholesterol, and thereby upregulating the LDL receptor to capture more LDL from the bloodstream. Now, statins, we have this newer medicine called Bemperdoric Acid. Okay, so it still works on the same pathway, the cholesterol biosynthesis pathway, but it's slightly weaker in its ability to reduce cholesterol biosynthesis. And the second thing to say is that it's a prodrug. So it's one of the potential advantages of it is that because it's only it becomes an active component when it only in the hepatocyte and not within muscle cells. And so one of the arguments is that it may be more useful for patients who are statin intolerant. So it works here on this enzyme called ATP citrate lyase to reduce cholesterol and then again upregulate LDL, the LDL receptor. Okay, and then out of the liver now into the gut, we have Azetamib, which again is very well established and is involved in reducing intestinal cholesterol absorption. Okay, and all three of these are all small molecules. And we go to this side of the picture here, and we come on to the Pcsk9 inhibitors. And there are two main types to be aware of. So there's an antibody approach to Pcsk9, and as I'm sure many of you are aware, Pcsk9 is a protein that's job is to target the LDL receptor to degradation. So if you can get rid of Pcsk9, you can upregulate the LDL receptor. And one approach is these antibodies. So they're extracellularly located and they bind any circulating Pcsk9. And the other approach, which is very novel, very new, very hot at the moment, is by actually turning off the tap and stopping Pcsk9 production through gene silencing. And this is a treatment called inclisiran, and I'll go into more detail about this in the next few slides. But this is an siRNA to Pcsk9 mRNA. And so you're actually blocking production of Pcsk9. So in this section, we'll talk a little bit about these very well-established drugs, the statins and Azetamib. These newish drugs, the MABs, the monoclonal antibodies to Pcsk9, and they've been available to us, I think, for 4 years now, we've been able to prescribe them. So I've called them newish. And then we've got these new drugs. So these, both the Bemperdoric acid and the inclisiran, have been available to us just this year, and they've both been NICE approved in the last few months. So let's look at statins first. This won't be new to you, but I just wanted to show you that these are the 5 main statins we have available in the UK. Simvastatin, especially at these high doses, has quite a substantial increased risk of myopathy, and so that is no longer recommended. So we don't really use much simvastatin anymore. Fluvastatin and pravastatin can be useful in people who've had statin related sort of symptoms, but you know they're much weaker, as you can see. So this is the dose, and this is the LDL reduction that you can get, LDL cholesterol reduction you can get with each of these doses, or we use them in specific circumstances. So, for example, in liver patients, etc. And then you've got these two, atorvastatin and rosuvastatin, and they were, especially rosuvastatin was limited in its use for a while just because it was still on patent, but it's now generic. So both of these are generic, so they're cheap and both very, very effective at lowering LDL cholesterol. And the other thing to say is that, doubling the dose only gives you an extra 6% reduction in LDL cholesterol. So, if a patient can only tolerate 10 or 20 milligrams, then actually that's still worthwhile giving them a very low dose rather than nothing at all. And often in the lipid clinic, when we see patients who've been quite intolerant to these higher doses, giving them, even 5 milligrams once a week will give you around a 20% reduction in LDL cholesterol. So it is worthwhile going with these lower doses in patients who can't tolerate the higher ones. And so for every 10,000 patients we treat with statins, in primary prevention, you can avoid 500 CVD events. In secondary prevention, it goes up to 1,000. But there will be 1 case of rhabdo, 5 cases of myopathy, and 75 new cases of type 2 diabetes. And so because of this, and this was found about 5 to 7 years ago, that actually statins do increase your risk of developing type 2 diabetes. We now do monitor HbA1c in these patients on an annual basis. But it's really important to stress to patients that the benefit of the statin outweighs the risk in terms of cardiovascular risk to them of the diabetes, because obviously, with diabetes, the thing that we're still, what people die of is cardiovascular disease. So the statin really the benefit of it is much higher than if they take it rather than not taking it. We still don't know the mechanism for this and why this happens, but certainly people who are at risk of diabetes, so are in that borderline range, are much more likely to progress into diabetes range. So it's shifting the population to a slightly higher HbA1c. So those who are at the threshold are more likely to tip over into the diabetic range. But starting the statin shouldn't affect the diabetes management per se. And statins are the most widely prescribed drugs in the UK. And despite having such an amazing evidence base, they really have been the victim of the media. And I'm sure you'll all have relatives asking you about whether or not they should be starting medicines and the muscle effects that statins have. And it's really hard when you've got the patient in front of you and they've been told by lots of different people that they know that statins are bad. And there's lots of RCT evidence showing that people have similar side effect profile in the placebo versus the active arm. But nevertheless, it can be a really difficult battle with some of our patients, and it requires time and education, and GPs often don't have that, which makes it difficult. And so because of this, we and this issue with perceived statin intolerance, we did a trial at Imperial called Samson, where basically people who'd stopped statins due to adverse symptoms, we gave them 12 bottles, and there was 1 bottle for each month, and they randomly had either placebo, atorvastatin 20 milligrams, or nothing. And they took these in a random order. Obviously, they knew the months where they were getting nothing, but they didn't know in the months where they did take a tablet whether it was placebo or atorvastatin. And we gave them all an iPhone, and they on there they were able to mark out of a scale of 0 to 100 how bad their symptoms were on a daily basis. And from that, we were able to work out what the symptom profile was on the 4 months patients were taking nothing versus placebo versus statin. And so this is an N of 1 trial. So we had data from on a patient level basis. And so we could show the patients themselves, okay, these were your symptoms on the placebo, these were when you were on nothing, and these were on statin. And what you can see here is that when patients were taking nothing, a lot of them still had quite a lot of symptoms. When they were taking placebo or statin, their symptoms were not significantly different in severity. And so this led us to, when we could show patients to themselves, you know, actually your symptoms weren't any different with placebo. Many of our patients, I think 60% from the trial, were able to restart their statin, which was really, really good news. And obviously, it's really difficult to do this in practice. We'd love to be able to give our patients with statin intolerance either a placebo or statin. And we're still working out some logistics with pharmacy to see if we'll be able to do this as sort of a diagnostic test of statin intolerance. I mean, obviously, there's ethics around placebo, but I'm hoping as a diagnostic test, this would be something that potentially we could do in the future for our patients to really help them, you know, decide if they are truly statin intolerant. Because I believe that statin intolerance in its own right is actually very rare, but perceived statin intolerance is very, very common. So that's enough about statins. Let's briefly look at ezetimibe. So ezetimibe is less potent than the statins. It usually gives about a 25% reduction in LDL cholesterol, and it works on the gut by decreasing cholesterol absorption via the Niemann-Pick channels. And this again leads to upregulation of the LDL receptor. It doesn't affect absorption of triglycerides, bile acids, or fat-soluble vitamins. And it's generally pretty well tolerated. So some of our patients who are statin intolerant, they will have ezetimibe instead. And unfortunately, obviously, you're only going to get that 25% reduction. So it's often not good enough on its own. And here is the outcome data for ezetimibe. So this took a long time to get. This was 7 years since randomization of patients on simvastatin or simvastatin plus ezetimibe. And this is the Improve It trial. This came out, I think, in 2013. But finally, we had outcome data for ezetimibe to show that, yes, it does have a cardiovascular benefit. There have been quite a lot of mixed messages along the way with GPs about negative trials and positive, and so, you know, its uptake hasn't been as good as it probably should have. So now let's move on to Pcsk9 monoclonal antibodies, and these are the newish drugs. So been around for around 4 years, and these are monoclonal antibodies to this protein called Pcsk9. And as I mentioned, this the Pcsk9 chaperones the LDL receptor reduction, okay, and thereby you have more circulating LDL cholesterol. But what's been found is that people who have loss of function genetic variants of Pcsk9 have upregulation of the LDL receptor and therefore lower LDL cholesterol in the blood, which leads to a reduced risk of MI. And people with gain of function mutations have quite a severe phenotype of familial hypercholesterolemia. So understanding the genetics led particularly the pharmaceutical industry to look further at the function of Pcsk9 and target it as a sort of therapeutic target. And the monoclonal antibodies, there's 2 of them, there's evolocumab and alirocumab. Both are quite similar in their efficacy. They're the first monoclonal antibodies to be licensed for the treatment, for the prevention of cardiovascular disease. And they're very, very potent. They reduce LDL cholesterol by around 60%. They come as a subcutaneous injection, and the patients can give the injection once every 2 weeks. And this is just some of the LDL-C lowering data. So if you just look at the green and purple lines, they're placebo, okay, over 12 weeks this is. And then with the red, you've got the top of statin. And you can see that there's around a 60% reduction in LDL cholesterol from that after that first injection. So at week 2, you can already see that sort of quite dramatic drop in LDL cholesterol. And there's some nice data looking at the effect of these MABs on the coronary arteries. There's intravascular ultrasound data that suggests that in patients with quite established cardiovascular disease and coronary atheroma, you get reduction in plaque in plaque within the coronaries at 18 months. And then there's the outcome data. So for evolocumab, there's the Fourier trial, and for alirocumab, there's the Odyssey trial, and they both show in people with established cardiovascular disease that this was a mean of around I think it was 2 years, median of 2.2 years, but there was already a reduction in this MACE event rate in the evolocumab arm, and the MACE was defined as CV death, MI, stroke, and hospitalization for unstable angina or coronary revascularization. So NICE have done a technical appraisal on these monoclonal antibodies, and because these are expensive drugs, they're really quite strict criteria as to who can have them. And so they've split them into people who don't have FH here at the top, and people who have FH. And if you have FH, you need to have an LDL of greater than 5, LDL cholesterol greater than 5, or you have to have cardiovascular disease and an LDL cholesterol of more than 3.5. And for those who are non-FH, those criteria are even stricter. So primary prevention, they're not recommended at all. But if you're at high risk, so you've already had an event, then you need to have a LDL cholesterol persistently above 4. Or very high risk, i.e. CVD within more than two or more vascular beds, you need to have a total LDL cholesterol of greater than 3.5. So that was the monoclonal antibodies to PCSK9. That was evolocumab and alirocumab. Now let's look at the 2 newer drugs that have become available this year. So the first is Bemperdoric Acid, and as we discussed, this is upstream of the statins in the cholesterol synthesis pathway. And as mentioned, because this is a prodrug and it doesn't get broken down to its active form within skeletal muscle, it seems to be more useful in patients who have statin intolerance, particularly related to muscle symptoms. And it is modest in its LDL lowering, especially when you compare it to the last graph of 60% lowering with the monoclonal antibodies. So this is on top of statin. You can see that patients get around a 15% reduction in LDL cholesterol with the bemperdoric acid. It's just a simple tablet that's taken daily. In the statin intolerance group, you get a little bit more of a reduction. It's around about a 20% reduction in LDL cholesterol. And this has specifically been recommended by NICE in people who where statins are contraindicated or not tolerated, or where Azetamib on its own doesn't control the LDL cholesterol. So quite a specific group of patients there. And then let's talk about inclisiran. So inclisiran, the name gives it away. So the all of these siRNA drugs have siran at the end of their names, and at the moment there's only 2 other licensed drugs based on this approach. So one for acute intermittent porphyria and one in a hereditary form of amyloidosis. So you know, inclisiran being approved for cardiovascular disease is quite a big deal, because it's, you know, very new mode of action. So it's going to be really interesting to see over the next few years what the sort of long-term safety data comes out as. But basically, as we discussed, PCSK9, usually its job is to chaperone this LDL receptor to degradation. If we can get rid of PCSK9, then we've got more recycling of the LDL receptor to the cell surface, so we can mop up more of that LDL cholesterol from the blood. And so the way that the way that inclisiran works is that, so it's an siRNA, so it's double-stranded, and it's bound to this moiety called GalNAc, which binds a receptor on the hepatocyte surface. So it's selectively taken up by the liver. And once it's in the liver, it binds to this RNA-induced silencing complex. And here you get sequestration of PCSK9 mRNA, which is then cleaved. And this happens on a continuous basis. So you get a massive reduction in PCSK9 protein production. And because of this mechanism of action, I mean, remarkably, this is a 6-monthly injection. So patients require the initial dose, another dose after 3 months, and then 6 monthly then on. And it's a subcutaneous injection. It's usually given by a nurse or pharmacist. And it doesn't need any refrigeration. It's fixed dose, even in patients with renal disease, albeit there weren't that many patients with renal disease included in the trials done so far. And this is data from the Orion 9 trial. So this was patients who have established cardiovascular disease. They were given here an injection at 0 months, then 3 months, and then 6 monthly after that. And you can see that after that 3-month injection, there was this sustained reduction in LDL cholesterol of around 50%. And this is on top of high-dose statin. And people have really been touting this as, gosh, is this a vaccination to cardiovascular disease? And, I think we just have to be really careful about that, because obviously, this is quite a new drug. We don't know about long-term safety. We haven't got cardiovascular outcome data as yet, but it is very exciting. And I think, the next few years will tell us what the effect will be. But I think we do need to be a little bit cautious about the way that this is touted, because you don't want patients to just stop their statins because they're on this 6-monthly injection. And NICE have recommended using inclisiran in patients who have established cardiovascular disease. So they've had an event and their LDL cholesterol is persistently above 2.6, despite taking a maximally tolerated statin with or without other lipid-lowering therapies. So that is lipid-lowering therapies in a nutshell. I haven't talked about Limitopide, which is also as an LDL lowering drug, but is only really used in specifically for homozygous FH patients. I think there's 15 patients in the country on Limitopide, and we look after 5 of them. So that's a bit more niche. I thought we'd concentrate on drugs that are being used in a much wider way. I just wanted to finish off with the national pathway for cholesterol management. We've talked a little bit about the confusion that NICE have provided us with their various guidelines and then many tech appraisals. And the problem is that each of these tech appraisals is done as a silo thing, just focusing on that one drug and not looking at where that fits in cholesterol management in general, and how GPs should be using these drugs. So NHS England has commissioned a clinical working group, which I've been involved in, and that has tried to put together all of this to give a pathway for primary prevention and secondary prevention. This isn't the final version, because it's gone back to NICE to include inclisiran. The NICE tech appraisal for inclisiran only came out a couple of months ago. So inclisiran will be included in this, and we're hoping to get this NICE endorsed within the next couple of weeks so it can be rolled out nationally. And Heart UK are going to be doing quite a lot of educational webinars and things to really publicise this. So I'm not going to go through this because it looks more complicated than it is, and we will be producing a sort of a simplified version of it. But hopefully it's comprehensive, and we've managed to get it all on one page. So people can know that they've got one place to go to look for the pathway they should be using. So I'm going to finish there. Let's see if there's any questions.
There's one question, Jay.
Yeah.
And it says, does NICE offer any guidance of when you might use inclisiran rather than evolocumab? Can I suggest everyone turn their cameras on, because it's actually sometimes quite difficult when you do these Zoom calls that you're just talking into a black hole.
Yeah.
It's actually quite nice to see people, if convenient, obviously. But
no, so they don't say which one you should be using in which situation. I think we're going to be producing from NHS England, we're going to produce like an FAQ, and that's going to be one of the questions that's being asked all the time as to when you should be using which. I mean, in terms of my patients, you've got outcome data, cardiovascular outcome data for the monoclonal antibodies. and we've been using them, we've got clinical experience, if they qualify for them, that's what I would be going with first line. And then second line, if you've got people who don't meet the threshold for the monoclonals, but meet the threshold for inclisiran, then it would be reasonable to start them on inclisiran. But bearing in mind, and having that conversation with your patients that this is quite a new drug, new mode of action, and we're yet to see long-term safety data.
Yep, no, that's really helpful. Thank you. Any other questions? Can I ask a very practical question? Okay, and this is the case. I recently saw a 78-year-old lady with just pre-diabetes, but had a TIA, and she was not on any statins. Her LDL was around 2.3. What is the role of statins or lipid-lowering treatment in someone, 78, who've got a background of risk factors?
You know what? I think it is case by case. If she's, it kind of depends on how frail she is, what her life expectancy is, and all of those things, and her kind of health beliefs in herself. I mean, if she's pretty fit and she's wanting to live another 10, 15 years, good quality life, then I would definitely think about starting her on a statin, because for sure, if she's already had a TIA, she's going to benefit from it. And I think there's quite a lot of data actually that now suggests that even in the older population, so people over 80, that there is quite a lot of benefit in terms of cardiovascular risk for them. It's just a case of having that conversation with them, because the problem is that the trials don't include these older cohorts of patients.
I know, but we're heading into sort of a population with lots of aging population, and I think some data is lacking there. But yeah,
I know what you mean. I mean, I guess the other thing to think about is in terms of sort of dementia and microvascular disease. That there's more and more data coming out supporting LDL lowering in these patients. So like I showed that heart age calculator, I think there's going to be development of a brain age calculator to look at your risk for dementia. And I mean, cholesterol is obviously one of them.
That's really helpful. Thank you. That's another question. Have you been checking uric acid before and after Bemperdoric acid? If not, are you doing any other checks?
Oh, that's a good question. So I didn't get to go through it in much detail, but Bemperdoric acid has been found to increase uric acid sort of significantly compared to placebo. Doesn't seem to translate in terms of incidence of gout, but I always ask patients before I start it if they have had gout previously, and we have added uric acid onto our new patient panel just to have that baseline uric acid there. Yeah, so but we don't do any other checks as such.
Thank you. And then there's another chat. So it just says therapies for Lp(a) lowering. So are there any therapies for Lp(a) lowering?
So at the moment there's nothing licensed specifically for it. We're doing 2 trials at the moment. We're doing one of a siRNA to Lp(a) and one of a antisense oligonucleotide. So we're involved in a couple of studies. One's a cardiovascular outcome study, so hopefully will give us that definitive answer of whether if you are able to lower Lp(a), whether we can actually reduce cardiovascular risk. So I think it's kind of watch this space, and we'll see, hopefully have the answer in about 3 to 5 years.
Okay, so Joanna's got a question. I'll let you pose a question, Joanna.
Hi, hello, sorry, it's a bit noisy. My question really was, when applying for approval for alirocumab, how strict is it that the LDL has to be less than 5? Like, I know sometimes it's a rounding error, or I mean, if you do it to 1 decimal place, it's closer to 5. And I just didn't know, with people who are approving the applications, what do they look at in addition to the LDL? And like the risk, obviously, whether or not they got secondary risk prevention, whether they got FH on board.
Yeah, it's a really good question, Joanna. I mean, it's a real bugbear of mine. It's something I've been trying to change for ages. But, the lab at the moment, they're reporting LDL cholesterol to 2 decimal places is nonsense. So we should be reporting it to 1 decimal place. Just trying to get the change through is a bit painful, but you know, actually it should be to 1 decimal place. In terms of the thresholds, I think it's very much dependent on pharmacy, your local pharmacists, who often hold the gates as to who gets it. And so having good links with your pharmacist and trying to explain to them, especially on a case-by-case basis, why a patient would benefit can be helpful. But yeah, it's because it's funded by the CCGs. So, but the pharmacists locally are kind of the gatekeepers of approving that funding. Does that make sense?
Yep. No, question. I want the slide that you put up about the percentage lowering between 40 milligrams and 80 milligrams of atorvastatin was really interesting, because it's just 6% difference between 40 and 80 milligrams. But in cardiology, almost everyone who's had an MI just automatically gets put on 80 milligrams of atorvastatin. So what are your thoughts on just giving sort of a blanket 80 milligram atorvastatin dose to patients post-MI, as opposed to maybe thinking about the 40 milligram dose more appropriate?
Yeah, our cardiologist asked me that the other day with one of the audit meetings, and saying, should we be continuing with this 80? And I think it is the right approach, because, when you've got a patient with ACS, you've got a real opportunity there. The patient's hospitalized and you're going to start the treatment. Once you've started, it's much less likely to get stopped. Whereas if you start on a lower, titrating up is always difficult. Titrating down is much, much easier. And I think patients, when they've had they've had an acute event, they're much more receptive to starting treatments. Yeah. So I've always supported that 80 milligrams. And in terms of intolerance and problems with it, I think, as you probably realized, I am slightly skeptical about statin intolerance and how much statin intolerance is prevalent. I think, perceived statin intolerance is much more of a problem.
Great.
Can I ask you one? Hello. I just want to ask you a question. If the patient is already on statin highest dose and as well as Azetamib, still is a LDL cholesterol about 2.6, would you go for inclisiran or would you go for evolocumab?
So with that patient, I think with 2.6, they wouldn't qualify for the monoclonal antibodies. So we couldn't give them the evolocumab, but they would qualify for inclisiran. So probably that would be the option that you would go for after having a conversation with the patient, checking that they're happy to go for it. Yeah. So evolocumab, it's 3.5 is that threshold?
Yeah.
Yeah.
If it is around 3.5, what would you go for it?
Oh, the monoclonal every time, just because we've got more data for them. We've got outcome data.
Okay. Yeah. Thank you.
Okay, that was a fantastic talk, Jay. Thank you very, very much.
Nice.
And if anyone else have any questions, do post it, and we can still address. If not, we have a 10-minute break. So, and then rejoin again at 3:10.
I'm just going to pause the recording in the break because...
Sounds good. Hi, can everyone see my slides?
Yes, we can see
Yes,
it. Yeah.
see them.
Okay, brilliant. Okay, so welcome back. This is the first time I'm doing a whole talk on Mentimeter, so I hope this will go smoothly without any hiccups. First of all, before I start, could I get you guys to again log into www.menti.com and then use the code here 51571289. And hopefully I can actually make this session a little bit interactive. I know it's late in the afternoon. Okay, right. So my name is Trisha Tan. I'm one of the metabolic medicine consultants, and a lot of my sort of research and clinics is in obesity and gut hormones. For today's talk, I'm going to actually take you through the just a very simple obesity case in terms of sort of how we make decisions. And hopefully at the end of this, we'll understand about the different choices of obesity treatment, understand some differences between the medical management and surgery, and learn a little bit about the advantages and disadvantages of surgery. I'm also very happy during the talk for anyone to interrupt and ask questions. Okay, so we're going to start with the case. This is a 45-year-old man with a BMI of 43 kilograms per meter square. He was around 130 kilograms. He had sleep apnea, hypertension, and pre-diabetes with a HbA1c of 46. He was referred to our clinic in view of worsening mobility and shortness of breath, and was extremely keen to lose weight. However, he did not want to have surgery. So, sorry, I'm just gonna. So what I want to do is gauge your opinion as to what would you recommend for this patient. Okay, so we know he is fairly metabolic. He has some risk factors for cardiovascular disease as well. So what would you offer him? Okay, so I think there's a bit of a spread here, but most people here, I think start off with some lifestyle advice, and then Orlistat and Saxenda, and interesting, no one's using MySimba. Okay, so what we're going to do is I'm going to talk you through sort of the current evidence in terms of these various treatment options, and then we'll come back to the case. Okay, so lifestyle management, we all know that, in most of our tier 3 clinics, the weight loss, achieved is really minimal. And the options of lifestyle management that we can offer patients are somewhat limited, but it makes sense to be the first step for these patients. This is the data from the Look Ahead trial, where they combined dietary restriction, exercise, and support, the intensive group versus the diabetes support and education group that they had. And this was in over 5,000 patients, and they followed them up over several years. And like most lifestyle intervention, you can see here that initially, there is a moderate response, and anyone who adheres to diet, adheres to lifestyle management, will lose weight. Okay, and this weight loss can range from 8 to 15 kilograms or more. But the problem with just lifestyle management is that over time people regain weight. And sadly, in terms of the long-term study in the Look Ahead, is that they showed that there was no improvement in mortality in the diabetes group over time. And most of you will be familiar with the DIRECT trial, where over 298 participants took part, but they were randomized to, very low calorie diet using products plus primary care structured programs, or to the standard care, which is very similar to most of our lifestyle clinics. And again, in this study, they showed that, in the first 12 months, a lot of patients achieved good weight loss, over 10 kilograms plus. But again, over time, there is some weight regain, but the weight loss benefits were sustained. Okay. And importantly, in the DIRECT trial, they did show that 45% of the patients with diabetes did go into remission using their remission criteria, so they could come off all diabetes treatment. And but this remission rate obviously dropped at 2 years to about 36%. Okay. The other thing that they did show is that the more weight you lose, the better the outcome. And certainly, the remission rate was was better achieved if you actually achieve a weight loss of greater than 15%. So all in all, yes, lifestyle management is good, but the problem is maintaining the weight loss achieved. So the next thing is pharmacotherapy. And some of you chose, I think, Orlistat as your first choice, which again is not an unreasonable option. Okay. But Orlistat essentially is a lipase inhibitor, and I will talk a little bit more about that next. But we only have a handful of treatments for obesity compared to all the other medical conditions that we currently have in terms of options of management. It's very limited. We've got Orlistat, we've got Mysimba, which is a combination of naltrexone and bupropion. Okay, this activates the POMC neurons and make you feel less hungry. Or we have the GLP-1 agents, which is basically an incretin, increases insulin secretion after eating, and also can impact on your appetite pathways. So Orlistat, which again is very much a first option drug that we often add to when seeing patients, unfortunately only leads to about 2 to 3 kilogram weight loss when compared to placebo subtracted weight loss. But it does work, it does help a little bit, but the problem is that as soon as you come off treatment, you will regain the weight, okay? And as it's stopping us from absorbing the fat, you can get steatorrhea, and therefore adherence is extremely poor to this treatment. The known adverse effects of hepatic damage is extremely uncommon. Then moving on to Mysimba, which hasn't actually had a very good uptake, I think partly due to the fact that it does have side effects of nausea, headache, constipation, dry mouth. But in terms of if adhered to, it does achieve a 7% placebo subtracted weight loss. There's currently also no long-term cardiovascular effects. So in general, I mean, it does work, but the compliance is not great. And the general uptake's not been good. So we come to our GLP-1 agents, Saxenda. This has been shown to be effective. The average weight loss achieved is around 6% placebo subtracted weight loss. It also, has been shown to reduce pre-diabetes to diabetes. And the cardiovascular data is also very promising, showing reduction in high-risk CV risk in patients with diabetes. And currently, it is funded if you have pre-diabetes, high cardiovascular risk, and a BMI greater than 35 or greater than 32.5, depending on ethnicity. And in terms of the follow-on from the Saxenda, we obviously have semaglutide. Wegovy is going to be the treatment for the licensed treatment for obesity. We currently have 1 milligram for diabetes, but we're hoping that this 2.4 milligrams will become available soon, because this can achieve even better weight loss than the Saxenda, which is 3 milligram liraglutide. The 2.4 milligrams of semaglutide has been shown to lead to about 12% placebo subtracted weight loss, and actually in some cases even more weight loss, up to about 20%. Okay, but currently not marketed or funded in the UK, but that should be in the pipeline. And I just want to also mention, some of you may have heard of Tesepatite. This is the first dual agonist, a unimolecular agent that consists of both GLP-1 and GIP, okay? And they've just recently completed the phase 3 trials for diabetes with superior sort of benefits in terms of improvement in HbA1c. And in terms of the weight loss, you can see here that it seemed to have achieved better weight loss compared to the 1 milligram semaglutide. So this is exciting because this, will potentially offer us more management option for our patients who are not willing to go for surgery. So to summarize, the GLP-1 analogs probably is the most reasonable choice at the moment, but it does have tolerability issues with nausea and vomiting as potential side effect. It is expensive, and often funding is an issue. So we often also see patients with obesity without diabetes, and because they don't have diabetes, they don't fulfill the criteria for getting Saxenda. Okay, and the other important question is, we're not sure how long should we be treating these patients for. So based on that background, can I revert back to yourselves to see if your approach to managing this 45-year-old gentleman have changed? I suppose maybe I should have had a choice of both lifestyle and Saxenda. Apologies for that, just looking at that now. But yeah, so I think most of you are going for Saxenda now. I mean, certainly it's the most efficacious treatment that we have, but bear in mind, 1/3 of the patients may not lose more than 5% of the weight. So it can be tricky. So our gentleman was started on Saxenda. Okay, he lost 5 kilograms in weight, 130 to 125. HbA1c improved, it's now 39. Do you think this is good enough? Can I get you guys to vote? Yeah, so I think most of you agree that it's not good enough. So what can we offer him? Well, we talked to him further and we discussed bariatric surgery. And in our unit, we offer 2 main types of surgeries, sleeve gastrectomy and Roux-en-Y gastric bypass. The gastric banding is hardly done now. There is another treatment option, which is a single anastomosis bypass, which I won't go into today. But the 2 most common operations are sleeve gastrectomy or gastric bypass. Sleeve gastrectomy, here you can see that the large portion of the stomach's been removed, leaving you with just a sleeve of a stomach. With the Roux-en-Y, you get a small pouch done here with the jejunum brought up to the stomach here. Okay. So I know some units still have gastric banding. What would you actually offer this gentleman? So he's done okay on Saxenda. He's lost some weight, but we felt that it wasn't good enough. His diabetes is, improved. What would you advise him to have next? So a lot of you are saying sleeve gastrectomy. Let's have more votes. This patient's sitting in front of us in clinic. See, I would love to have an interaction with you to discuss why we've chosen which surgery. So do add comments to the chat. Any more votes? Okay, so I think, okay, majority of people said sleeve, but a good number of you also said Roux-en-Y. So what are the advantages and disadvantages? Well, essentially, I think bariatric surgery has many advantages as a whole, okay? It's a one-off treatment. You know, we have shown long-term cost effectiveness with surgery, and there's good data on benefits on mortality, okay? The differences between the surgery, certainly the current data for sleeve gastrectomy is almost as good as the RYGB, but we've got more data on RYGB. It's an operation that's been around for longer. But the initial weight loss, certainly for sleeve gastrectomy, has been reported to be about 15 to 25% and 20 to 30% for the Roux-en-Y gastric bypass. And sleeve gastrectomy, technically, I think surgeons prefer it because it's easier. And it certainly is becoming the more popular operation. However, we are not clear which is better for the long-term weight loss. Okay, there are many studies coming out here, but I think you know, over the next 5-10 years, I think it'll become clearer as to whether both operation will convey similar benefits. And there is, however, some suggestions that there's possibly more weight regain with sleeve gastrectomy. In terms of studies that have compared the sleeve gastrectomy versus Roux-en-Y, this is an American study where they've looked at over time the proportion of participants who continue to maintain, for instance, greater than 5%, greater than 10%, greater than 20%, or greater than 30% weight loss. And if you look here, you know, if we look at greater than 5% weight loss, well, it's fairly similar, although maybe the Roux-en-Y is that bit better. If you then jump to the greater than 20%, you can see that in the bypass, Roux-en-Y gastric bypass, a higher proportion maintains this greater than 20% weight loss. But over time, for, you know, both operations, this does go down. So there's always a tiny bit of weight regain. Okay. Nevertheless, weight loss is important, but the surgery also conveys other benefits. Okay, so diabetes remission is an important outcome, and certainly, you know, 4 in 10 patients after Roux-en-Y gastric bypass can achieve diabetes remission. There's reduction in cardiovascular risk, reduced cancer risk, and also improved quality of life. There are, however, disadvantages, and they include things like micronutrient deficiencies, post-bariatric hypoglycemia, post-op complications such as pain, osmotic dumping syndrome, and increased incidence of depression and increased alcoholism. So just going to talk a little bit about the complications. In terms of micronutrient deficiencies, all patients who've had bariatric surgery, we now recommend, and as per BOM's guidance, to be on lifelong calcium vitamin D replacement, vitamin B12 injections or oral B12 tablets, lifelong multivitamins, so Forceval or Centrum is what we tend to recommend, and iron treatment as required. And the problem with a lot of the long-term follow-up patients is that they are lost to follow-up. Most units, our unit, for instance, discharge patients after 2 years, and ensuring that patients remain on their vitamin supplements is actually a major issue. And in terms of the other common, increasingly common complication from bariatric surgery is post-bariatric hypoglycemia. Previously poorly recognized, but I think increasingly recognized and increasingly reported. Okay, the early figures of post-bariatric hypoglycemia is between 0.1 to 1% based on hospitalized reports. But I think with the increased recognition of this problem, this number has now increased. If we rely on report in symptoms, then the incidence is much higher, 1 in 3 patients, okay? And it occurs after both Roux-en-Y gastric bypass and sleeve gastrectomy, but more in Roux-en-Y. And there are major implications because it can be disabling to patients, and some patients cannot drive because of the hypoglycemia. So why do patients get hypoglycemia after bariatric surgery? Well, one of the reasons is that after bariatric surgery, there is increased glucose variability. And I'm just going to explain to you a little bit about what glucose variability is, okay? So glucose variability is something that is recognized in type 2 diabetes, okay? And also previously recognized as a risk factor for hypo. And if you look at this patient A and patient B, okay, these 2 patients have the same mean glucose and the same HbA1c, but patient A is getting more hypos. And the reason for this is that they're getting, the glucose is swinging around, fluctuating more, as you can see here, okay? So where you've got high GV, this is linked to increased hypos, and the low GV, reduced risk. So what happens after bariatric surgery? So here's some data from our group. This is basically ambulatory glucose profiles from continuous glucose monitoring in patients, okay? And this is before bariatric surgery, 1 month after Roux-en-Y gastric bypass surgery, and 1 year after Roux-en-Y gastric bypass surgery. I'm just going to navigate you around this slide. Okay, the dark line here is the median glucose level. Okay, and this is the shaded area is the 25th to 75th interquartile range, and the dotted line here is the 10th to 90th centile. And you can see here that before bariatric surgery, the patient had a high mean glucose, yeah, but just moderate GV, okay? After bariatric surgery, the mean glucose drops. In the first month, when they're not quite eating normally yet, the glucose variability remains fairly similar to preoperatively. But then at 1 year, when they're back to eating normal foods, although the mean glucose is much the same as at 1 year, you can see here there's increased glucose variability. And because you're getting highs and lows in sugars, that there's then increased risk of hypoglycemia. And post-bariatric hypoglycemia, certainly in our cohort of patients that we've studied, we've shown that if we actually did continuous glucose monitoring, we detect evidence of hypoglycemia in 1 in 2 patients after RYGB surgery. And the hypoglycemia is linked to the high glycemic variability, and this is often related to what a patient eats, okay? And therefore management for post-bariatric hypoglycemia is the mainstay of management is dietary. The role of medications are unclear, and for today's talk, I won't touch on it too much, apart from telling you that after in post-bariatric hypoglycemia, we've consistently shown that this is related to higher GLP-1 secretion, leading to excessive insulin secretion, and therefore sort of like an overswing phenomenon leading to hypoglycemia. And then several drugs that people use to try and treat the hypoglycemia, but all in all, it has not been very effective. However, there's a trial currently assessing a GLP-1 antagonist, so it's Xanthine 939, because we know that the GLP-1 secretion is high, and the data on this is promising. So now I'm going to go back to my case. We persuaded our patient to have bariatric surgery. He lost a further 25 kilograms. He's now 100 kilograms. His sleep apnea has improved. His diabetes continues to be in remission, and his hypertension improved, and he's off treatment. And he has no reported post-bariatric hypoglycemia. So a very simple, standardized case. Essentially, I hope I've given you an example about sort of the things to consider in obesity cases. Our treatment options are limited, but I think always important to think about what are their goals when they see us in clinic, and and sort of weigh that out with the realistic expectations in terms of the things that we have available for the patients. And always important to discuss the advantages and disadvantages of the treatments that we can offer and complications. There's often a reluctance to go for surgery, but we know that in general, most of the other non-surgical treatments that we have to date are suboptimal. So we need to also sometimes, in the cases that we think will benefit, try and help them overcome the reluctance to surgery. And you can do that by explaining the risk and benefits. Okay, so that's the end of my talk. I've not dragged it on for too long because I was keen to make this session interactive, and I'm open to questions. Questions or cases that you have that you want to discuss?
Tricia, I think Roberta's got her hand raised. I think she has a question.
Okay, I'll stop sharing. I couldn't see the screen. So Roberta.
Hi, Tricia. Thank you for the talk. Do you have any experience on gastric balloon?
Yes, so we do offer gastric balloon. Sorry, I didn't, but that's often temporary. And we sometimes use that as a stepping stone to then proceeding to bariatric surgery. So some of the, morbidly obese patients that we're trying to get them to lose a bit more weight beforehand, or occasionally, we consider it in patients who we're not sure whether surgery is actually going to benefit them, because there are poor responders as well. So one thing I would say is, all the medications, you've got the responders and non-responders, and treating obesity is complex because it's not just, we don't have a single target. We're going to improve this, we'll give you a drug that will treat this. So it's often complex. And certainly what I've not covered today is the fact that the role of the psychology and psychiatrist team and dietitians within the management of these patients are really, really critical. So yes, we do use the gastric balloon. Does that answer your question?
Yes, absolutely. Thank you.
But it's temporary.
Okay.
There are actually quite a few interesting endoscopic procedures currently being trialed. So it may be that in 5 to 10 years, if they prove to be effective, we will have more options. But treating obesity is tough because we have very little tools. And bariatric surgery continues to be the most effective. Now I can see there are questions. Let me see. So, regarding long-term risks of papillary carcinoma following Saxenda, Is this confirmed, and what are the suggest mechanisms? So it's actually medullary thyroid cancer. And the data that has been shown is actually only in the preclinical data. To date, we have not shown that I'm aware of the GLP-1 being linked to MTC in humans. But obviously, you know, the only way you can find out if you do a thyroidectomy. The trials have monitored people's calcitonin levels, because the calcitonin is released by the medullary thyroid cells. But to date, there have been no reported cases of MTC. Does that answer the question? Okay, so I'll move to the next question. Are there any patient factors that can lead to choosing RYGB over sleeve gastrectomy? Yeah, I think this is always a tricky one. You know, in general, I think patients, you know, when you discuss the operation to them, the sleeve gastrectomy, we have to be honest, right? When we talk to them, it's going to be the simpler operation, the operation with the lower risk. And the surgeons definitely prefer this. But certainly I would always, if I've got a patient with significant risk factors, especially diabetes, always push for RYGB more than sleeve gastrectomy. But, you know, if you know, they want sleeve gastrectomy, it's still going to benefit them. Does that answer the question? I feel like I'm talking to a black hole, do you see? So I would like you guys to be more interactive if you can.
Sleeve as well, all the surgeons always try and avoid that in patients with significant reflux. So then that,
yes, that's right,
more towards an RYGB.
Yes, good point. So the reflux is a big thing. So if you've got reflux, they will have RYGB instead of sleeve. Okay, so do you see any role of SGLT2 for obesity, diabetes risk patients in the future? I must say, initially, I was hesitant about using SGLT2 in patients after bariatric surgery, more from a mechanistic perspective, because I know that SGLT2 increases glucagon, and we see that also after bariatric surgery. So I was worried about risk of DKA. But over time, we've increased our experience with using SGLT2, and it seemed to be fine, it's effective. But I would always say that to the patient that they must make sure that they're well hydrated. And if they are unwell for whatever reason, to stop the SGLT2. So I take quite a cautious approach on that. And in terms of added weight loss, some of the patients, this is in our own experience, have lost further weight with the SGLT2. Okay, I hope that's answered that question. There's one saying, there's a lot of whey here, but I think everyone used whey as login, so I don't know who this person is. GV is considered as a risk factor for cardiovascular disease. And so what is the point to undergo bariatric surgery, even if the patient has pre-diabetes, and so diabetes will end up with a GLP-1 agonist? So yeah, this is really interesting, but I think we're doing a lot of work around GV, and I think how we refer to GV in a bariatric patient is different to the GV, increased GV in the type 2 diabetes. It's not clearly defined. In the bariatric cohort, the time in highs and lows are much shorter, but more frequent in someone who's had bariatric surgery versus someone with type 2 diabetes. So I think, I hope, you know, in the near future, we can actually define this in more detail, but it's a good point. And but clearly, despite demonstrating increased GV after bariatric surgery, your cardiovascular risk goes down, yeah, both mortality and morbidity.
Thank you.
That's good. Oh, thanks. Good to see someone. Okay, so that is that answer. What about the counterbalance study and calorie restriction instead of surgery? Was this what you mentioned earlier about how weight loss only sustainable if, so I think all lifestyle diet trials work, okay? So, but, you know, the thing that we know from over 50 years of trials is that it works, but the problem is maintaining the weight loss long-term. And to date, only bariatric surgery is the one thing that have shown, you know, long-term maintenance of weight loss. And the 15 kilogram weight loss is, I think that's been shown sort of in the direct trial, is that if you want to achieve diabetes remission, but the diabetes remission is dependent on definition, is that if you get greater than 15 kilograms, you can increase the likelihood of you coming off all your diabetes treatment. Does that answer the question? Okay. And then here, actually logged in way. Okay. Any other questions? We still have a bit of time if anyone else wants to discuss any cases. No? Okay. Right, as Roberto's on, I am now going to hand over to Roberto, who is a clinical research fellow in hepatology. And she's currently also doing a PhD in NAFL. And Roberta is going to talk to us about non-alcoholic fatty liver disease. Where do we start?
Thank you. Thank you very much for this invitation. And so I thought, I hope you can see my slides.
Yes, we can.
Fantastic. Okay, so just one first slide, just to introduce why it's important to talk about NAFLD in the UK in general, of course, but in the UK in particular. So here I show a graph coming from data from the Lancet Commission dated 2018. So you can see here the mortality rates of different causes of major health issues in the UK. And you can see that liver disease is the only major cause of death, which is still rising in the UK, and we have seen a 5-fold increase in mortality in liver disease. This is particularly significant in the young ones, in those aged between 35 and 49 years old. And this increase is mainly driven by alcohol and non-alcoholic fatty liver disease. And this is the reason why talking about NAFLD is quite relevant. And we will all deal with the NAFLD in our clinics. So in this talk, I will cover the definition of NAFLD, the prevalence, quickly the pathophysiology and natural history, the diagnosis and non-invasive assessment, the management, and then I will introduce you our NAFLD clinics and St. Mary's Hospital, or at least the model we follow. So non-alcoholic fatty liver disease starts with an accumulation, an abnormal accumulation of fat in the liver, which is called hepatic steatosis. Some patients may have inflammation or hepatocellular ballooning, which identifies what we call non-alcoholic steatohepatitis or NASH. All patients may potentially develop some scarring and fibrosis down the line, and those with a heavily scarred liver develop cirrhosis. So in those patients, the liver is heavily scarred and we may start seeing the liver complications. So NAFLD is a metabolic liver disease, is strongly associated with insulin resistance and with clinical hypertension, dyslipidemia, diabetes, and visceral obesity. So as you can imagine, since the metabolic risk factors associated with NAFLD are very, very common and increasing in their prevalence, NAFLD is also a very common liver disease. So it is estimated that the prevalence of NAFLD in the general population is up to 25–30% worldwide, so on average worldwide. If you go to Paddington Station and you choose 100 random people, 25 or 30 out of them will have some sort of fatty liver, NAFLD. Of course, there is some variability across the world. So the 25% is the prevalence of NAFLD in Europe and North America, but the prevalence goes up to 30% in South America and in the Middle East, and it goes down to 13% in Africa. These changes in prevalence are probably due to reflect, let's say, or follow or mirror the different prevalences in obesity, or different obesity rates in these countries. But we also know that there is a different genetic predisposition or an ethnic level towards developing fatty liver and complication out of the fat in the liver, like scarring. So the prevalence of NAFLD is even higher if we consider high-risk groups of patients. So NAFLD is as frequent as if in 50% of patients with type 2 diabetes, up to 45% in a patient with a BMI greater than 30, and up to 90% among those with who undergo bariatric surgery. This is very important. But it's also very important to keep in mind that we have a small portion of patients with the prevalence, it's different and may vary across different studies. So this patient may have NAFLD and fibrosis, even though their BMI is within normal range. And this is what we call lean NAFLD. Actually, this is a small proportion, but still very relevant in our clinics. And it is, lean NAFLD is thought to be associated with sarcopenia, so with loss of muscle mass, given the same BMI. But also, in this patient, we may have a very strong genetic predisposition towards the disease, or a very strong abnormal metabolic status. Or again, there might be also a difference in how lean NAFLD has been defined across the studies, because now we know that BMI presents ethnicity adjusted cutoffs, but this was not the case several years ago. So how big is the problem in the UK? So these are data from 2018. At that stage, we knew that nearly 14 million adults were estimated to have NAFLD, and over 2 million of people having NASH in the UK and Ireland. So the prevalence is very high in the UK, and of course it is expected to rise even further, considering the expected increase in diabetes prevalence and obesity rates, especially if we consider childhood obesity, which is increasing over time. And of course, we're going to see the consequences of such increase in the long term. So very briefly, what are the factors associated with the development of NAFLD and the progression of liver disease in these patients? So first of all, of course, we have the presence of metabolic risk factors in different combinations. So type 2 diabetes, insulin resistance, obesity, and hypertension. NAFLD is also very much associated with environmental factors such as the lack of exercise and, of course, diet rich in saturated fats and fructose and low fiber intakes. But also there's a lot of research investigating how our gut microbiome may influence our response to calorie intake, but also our gut microbiome may modulate the way we respond to and the way we absorb some nutrients. And actually the presence of particular or the abundance of particular species within the gut has been associated with the production of hepatotoxic molecules, which reach the liver through the portal vein, and within the liver they may cause apoptosis and necrosis, and of course trigger the innate immunity within the liver, but also systemically by the via the activation of macrophages and also the production of pro-inflammatory cytokines. In particular, on a liver point of view, on a liver level, the fat with these, considering this pro-inflammatory environment, the fat within the liver gets inflamed, and it develops what we call lipotoxicity, which is one of the driver of fibrogenesis. And finally, even though NAFLD is very much considered as a sort of acquired liver disease or very much associated to environmental factors, There is a small box of genetic factors which may influence and may explain some extreme cases like the lean NAFLD or differences across ethnicities. So here again we have the full spectrum of the liver disease, simple steatosis, NASH, and cirrhosis, and of course we have the fibrosis progression throughout the years. So some patient may develop fibrosis, other patient may not develop fibrosis for their life. And why are we so obsessed with fibrosis progression or with the development of fibrosis? Because many studies have shown that fibrosis stage is the main clinical predictor in these patients. So we always need to keep an eye on fibrosis stage and to stratify the patient according to fibrosis stage. Interestingly, hepatic steatosis or simple fat in the liver for a long time was thought to be a benign condition. Actually, we now know from paired biopsy studies that also patients with simple steatosis may progress to fibrosis. Up to 25% of them may develop fibrosis in the long term. And those with NASH develop fibrosis more frequently, up to 35%. And among those with NASH and advanced fibrosis, so fibrosis F3, 20% of them, for some reason, become fast progressors, and they move from F3 to F4, which is cirrhosis, in 2 years. So they are considered very fast progressors. Factors that have been associated with a faster progressions of fibrosis are uncontrolled diabetes, developing or having for a long time morbid obesity, of course, taking other hepatotoxic factors like alcohol consumption. And of course, again, we have the genetic factors which may influence these extreme faster progressors. Cirrhosis from NASH is slightly different from cirrhosis from other causes of liver disease. The cirrhosis from NASH is less progressive. So patients with NASH cirrhosis do tend to stay stable for a very long time compared to those with a cirrhosis from viral hepatitis or alcohol. We still need to keep an eye on them and screen them or monitor them for hepatic complication and also for hepatocarcinoma, which is the hepatic malignancy. So the incidence of HCC in those with NASH cirrhosis is much lower than other than cirrhosis from other etiologies, but it's still important to keep in mind. And another interesting thing is that the progression rate of fibrosis shows a faster rate as soon as we get to cirrhosis. So, for example, to progress from F2 to F1 to F2, it takes on average 14 years, while it takes 7 years to progress from F3 to F4. So the pace of fibrosis progression gets faster with the worsening of fibrosis. And this is also another thing to keep in mind, because patients who present with advanced fibrosis will progress in a very fast way. Another interesting thing is that the main cause of mortality in this patient is cardiovascular risk, is not liver events, liver-related events. And this is, I think, quite obvious because of the metabolic syndrome and all the metabolic factor that this patient carry. So cardiovascular disease is the cause of 33% of the death in these patients, and important cause of morbidity. So these patients with cirrhosis are very stable with their cirrhosis on the liver point of view, but they may have had stroke and cardiovascular disease. So they become such complex patients for the whole picture, not only on the liver point of view. The second cause of mortality in this population is extrahepatic malignancies, especially gastrointestinal and breast cancer. But there is, we know very little about it, this relationship between extrahepatic malignancies and NAFLD. It is thought to be mediated by the risk for malignancies, which is typical of obesity, so not peculiar of NAFLD, but mediated by obesity. But we still need to study more about that. And finally, the third cause of mortality is liver-related complication. So how do we diagnose the disease? Patients do not get to the doctor attention because of they are symptomatic. Most of them are totally asymptomatic. They may have an enlarged liver that we can appreciate on physical examination, but again, that is very specific. Now, the diagnosis it's usually incidental. So it usually comes from a finding of fatty liver on ultrasound, which was ordered or requested for other reasons, such as investigating abnormal liver function test or investigating abdominal pain. So, and this is how we found out about the fatty liver, and then the workup for the fatty liver starts. But very interestingly, it's usually everything starts with the finding of abnormal liver function test by the GP, then it triggers the ultrasound and we found the fatty liver. But for this reason, actually, NAFLD is now the most common cause of abnormal liver function test investigated in the UK. But actually, fun enough, abnormal LFTs are the presence of abnormal LFTs or the entity of the abnormal LFTs do not really reflect the severity of the liver disease. So we very commonly see patients with cirrhosis and normal LFTs or advanced fibrosis and LFTs, and patients with simple steatosis and AST and ALT on 150. So LFTs are not very useful in this population unless we witness a very important change, like in the level of 100. So actually, because for many years, the diagnosis of NAFLD relied on abnormal liver function tests, we think and we estimate that there is a huge population of undetected NAFLD, especially among those with normal LFTs and younger age, which essentially is undetected in primary care. So there is a lot of work to try to dig this patient out and to find a way to effectively screen them, which will not rely on abnormal liver function tests. So once we receive a patient with fatty liver on ultrasound, with or without normal LFTs, first thing we should rule out all the other causes of liver disease, because NAFLD is a diagnosis of exclusion by definition. So we will request what we call a full liver screen. So the markers of viral hepatitis, ferritin, ceruloplasmin, alpha-1 antitrypsin, and autoantibodies for autoimmune hepatitis. We also check with the patient his medical history, in particular the use of hepatotoxic medications such as amiodarone or tamoxifen or methotrexate. And of course, we need to check for alcohol consumption. We see that in real life, we do see many patients with both alcoholic and non-alcoholic fatty liver disease. So once we've done the diagnosis and the full liver screen comes back as negative, we do want to stratify the patient according to their disease severity. So the gold standard for diagnosing NASH and for staging the liver disease in this population is a liver biopsy. Because a liver biopsy is the best way to assess steatosis, ballooning, and inflammation, which are the histological features defining NASH, and the amount of scarring and fibrosis within the liver. But of course, liver biopsy carries its own risk, such as bleeding risk, is expensive, is painful, is invasive, and is not very well accepted by most of the patients. For this reason, it's impossible to think that for all our patients to undergo liver biopsy. And there has been a lot of research and a big scientific effort in trying to identify some tools or some scores called non-invasive markers, which could allow to stratify those patients without doing a biopsy, essentially, in a non-invasive way then. So considering the three key features that we assess on histology or in general, which define the disease, we have steatosis, NASH, and fibrosis. So we have a a large amount of non-invasive markers investigating on predicting the presence of steatosis, from blood tests, fatty liver index, steato test, the CAP score, which is applied on FibroScan. I will talk about it later, and imaging-based techniques. We also have some markers investigating or predicting the presence of NASH, but none of them actually is quite accurate. So the diagnosis of NASH still remains histology proven. There's no way we can predict the presence of NASH without doing a biopsy. And finally, fibrosis. We have many non-invasive markers, and we'll talk about them in particular because fibrosis, again, is the main clinical predictor for this patient. So the first thing we want to do is to stratify the patients according to their risk of having fibrosis. So among the non-invasive markers of fibrosis, we don't use just them randomly in every single context. They are kind of clustered in 3 groups, and we do apply them according to different contexts. So we do have the blood-based non-invasive markers of fibrosis. The most common ones are FIB4, NAFLD fibrosis score, and the ELF. They are based on blood tests and clinical features of the patient, and they are mainly from bloods. And then on the other side, the extreme side, we have non-invasive markers of fibrosis based on imaging techniques such as ultrasound and MRI. And in the middle, let's say, with a good compromise, we have FibroScan. So as you can imagine, blood-based non-invasive markers are very cheap, are very easy to calculate. You can calculate online, and they are widely available everywhere in the country. A doctor can calculate those tests, and they have a high negative predictive value. So they are thought to be very good at ruling out the presence of significant fibrosis. These characteristics make these non-invasive markers very suitable for screening in on a large-scale population and to be used then in primary care and be calculated by the GP. On the other side, we have these very complex, very fancy methodologies like MRI elastography or ARFI or share wave based on ultrasound. They do provide, to be honest, a very comprehensive examination of the liver because, for example, compared to a biopsy, they do assess a larger volume of the liver, but they are very expensive. They are available only in specific centers, very expert-centered tertiary care, and usually we request them in selected cases, such as in the setting of a clinical trial, essentially. So as a good compromise, and you can already see that we favor a lot of FibroScan. So the FibroScan is a very good compromise between the two extremes. So FibroScan has a very reasonable cost. It's almost like an ultrasound or even cheaper than that, and has a very high positive predictive value. So we know that patient with the abnormal FibroScan will probably have some sort of liver damage behind. And FibroScan is mainly used in tertiary care and in our NAFLD clinic. I will mainly talk about the FIB4 and the FibroScan because those two are the ones we use in clinic and we do recommend to the GP in our Northwest London GP pathway. So the FIB4, you can calculate it online, is widely available. The things you need to calculate it are AST, ALT, platelet, age. Of course, it's very easy to interpret and widely available, as I said, even though AST is not always available. And this has always been a mystery to me, why we don't have AST on liver screen. But anyway, so when we calculate FIB4, we get a score by which we can allocate the patient in one of the 3 risk groups. Essentially, we use a cutoff of 1.3 and 3.25. So a patient with a FIB4 lower than 1.3 is a patient at a very low risk for having significant fibrosis. So these kind of patients probably have only steatosis, they can remain in primary care. While those patients with FIB4 greater than 1.3 have an intermediate risk of having significant fibrosis, as those with FIB4 greater than 3.25 are at even higher risk for advanced fibrosis. So in this case, we do advise the GPs to screen patient with metabolic syndrome with FIB4, to calculate the FIB4 in this patient, and to refer to us for a FibroScan all patients with FIB4 greater than 1.3. And this is based on latest European guidelines. And then we have the Magic FibroScan. So the FibroScan is a very nice technique. It's based on analyze the textures of the liver based on shear waves. It's a very quick test. It takes just 2-3 minutes to do it. You can do it bedside. You have a portable version of the tool. You can bring it to clinic and do a real-time FibroScan. It's a great technique. Patients love it, so they like repeating the test even after 6 months, because they do like seeing also changes on the FibroScan. And we do need 4 hours of fasting. Has a very good reproducibility between different users. Always keep in mind that there are no universal cutoffs for FibroScan, and that the cutoffs are very much liver disease specific, and this is very important to keep in mind. So apologies for this busy figure. So essentially, just to show you that cutoffs for different liver disease stage, the cutoff for the FibroScan, we have it here. So the cutoff for liver stiffness, and here you can see in each bar showing a different cutoffs for F0, F1, F2, F3 for different liver disease, different etiologies of liver disease. You can see that they do different very much. So it's very important to keep that in mind. For NAFLD, actually, we have 2 main cutoffs that we do apply in clinical practice. One is liver stiffness of 8.1 kilopascal, which identifies or predicts the presence of significant fibrosis, which correspond to fibrosis stage 2, greater or equal to 2. And liver stiffness greater than 12 kilopascal, which predicts quite accurately the presence of advanced fibrosis, which is fibrosis stage greater or equal than 3. And this is a classic report that you will find in our structure notes for the patient. I thought it might be useful to show you one, just so that you will get familiar and interpret it the next time you find it. So this is a FibroScan which measure both the stiffness and the CAP score. So the blue one, the CAP score, measuring decibel per meter, is a non-invasive marker of steatosis. So it measures the presence of fat. We consider we can diagnose the presence of fat in the liver when a CAP score is greater or equal than 260. And here in orange, we have the elastography, which is measured in kilopascal, and is the actual liver stiffness of measured by the FibroScan. And here on this value, we do apply the 2 cutoffs of 8 and 12. So when the orange value is greater than 8, the patient has a very high chance to have significant fibrosis. Greater than 12, advanced fibrosis. So I cannot emphasize more that we need to stratify the patient according to fibrosis. I hope this is clear enough. And so we end up having more or less 3 main groups of patients. After we see them in clinic, exclude other causes of liver disease, and we stratify them for the presence of fibrosis. So the first group with a mild NAFLD are those without fibrosis or with very early fibrosis, like F1 or F2. Then we have those with advanced fibrosis, which is F greater than 3, and those with cirrhosis. So patients without fibrosis or early fibrosis, they have a low risk of liver-related complications. And in this patient, this patient have a very low risk, and they can be actually discharged back to primary care and be followed up within primary care. They don't need to stay in tertiary care in the NAFLD clinic. We do recommend, and guidelines recommend in this patient, to optimize cardiovascular risk factors for obvious reason, to keep the patient under cancer screening keeping their cancer screening up to date according to national guidelines because of their risk. And we do advise them to lose 5% of their body weight, because in this patient with mild NAFLD, this goal is good enough. In those with advanced fibrosis, they are at higher risk for liver-related complication, but also for cardiovascular events. So again, the same kind of recommendation, but also we advise them to lose more weight because this has been demonstrated to improve the fibrosis in the liver and regress NASH. In a group of patients, the morbidly obese one, we can consider bariatric surgery or also clinical trials because we run many of them in the liver unit. And then those with cirrhosis, same kind of recommendation. They are very high risk for hepatic decompensation and liver-related event. We advise them to lose no less than 10% of body weight. And of course, this is a tricky category because these patients tend to have muscle waste, sarcopenia, or obese sarcopenia. So it's quite tricky and they do need a tailored approach. And then we need to follow them up for possibility of hepatic complications such as a hepatocarcinoma or bleeding. And I will not bore you with that. I will just to tell you that the lifestyle modification that we recommend is to the patient is to follow a Mediterranean diet and a combination of physical activity, of aerobic and strength exercise, mainly because the Mediterranean diet with or without polyphenols enrichment is the more evidence-based dietary regime for treating NAFLD. Also because actually it has a naturally low carbohydrate intake. And of course, we have many patients asking about these very fancy diets, like you know, the very new ones, like intermittent fasting, low carb diet, and ketogenic. We do not recommend them at the moment because they are not there is not much evidence supporting the using those patients, and they also should be considered for selected patients under strict medical control, but usually we don't recommend them. There is no medical treatment at the moment for these patients. We have a large number of molecules being tested in phase 3 and in phase 1 and phase 4 clinical trial. The GLP-1 receptor agonists are by far the most promising at the moment, and we are running many clinical trials with semaglutide and Tesepatite in the unit. And finally, last 2 slides to show you, to introduce you the fatty liver clinics we have at St. Mary's Hospital. Those are, we have 2 clinics running every week, and we have a multidisciplinary team because this patient needs a multidisciplinary approach. It's us, the hepatologist, the endocrinologist, Dr. Yi. We have a diabetes nurse and dietitian where we can send the patient for further help. And we have also recently started an NAFLD MDT meeting every 2 weeks where the bariatric colleagues from bariatric team and endocrinology and histopathologists join us to discuss specific cases. And we have also a fast track to the cirrhosis and radiology MDT should we need any further support for these patients. Overall, we've seen more than 800 patients so far over the last years, and we do hope to expand our team with a psychological support, which could be a psychologist or a nurse trained in behavioral therapies, because this patient really needs psychological support. As you may have experienced already in patients undergoing bariatric surgery or with obesity in general. So psychiatric comorbidities are very highly prevalent in this population. Almost 30% of the patient has depression, and we have recently demonstrated that up to 25% of patients with NAFLD have binge eating disorder. So psychological support needs to be included in their care plan. And finally, I will show you this pathway that we are currently using for referring patients for primary care. So the GPs can screen patients in their high-risk group or for fatty liver, or pick up patients with fatty liver on imaging with or without abnormal LFTs. The first triage in primary care should be based on FIB4, and we ask them to refer for a FibroScan, those with FIB4 greater than 3. In tertiary care, the liver services, we then triage further the patients using the FibroScan, and we keep in clinic essentially those with stiffness greater than 8, or those with CIF lower than 8, but with high risk for progression. And probably we keep them with a yearly follow-up rather than 6 monthly, just to keep an eye on them. And then, of course, the patient follows the normal diagnostic pathway with liver biopsies and possible access to clinical trials. We want a referral from metabolic medicine and bariatric services. These can go straight to the FibroScan because these will triage the patients and identify those needing for specialist support from us. So my take-home message, very easy ones. NAFLD is an increasing cause of liver disease and affects one-fourth or one-third of the population worldwide, depending on the country where you are at the moment. NAFLD should be suspected, I would say NAFLD and significant fibrosis should be suspected in all patients with metabolic syndrome, regardless of the level of liver function test. Fibrosis is the main prognostic factors because those with advanced fibrosis and cirrhosis are at higher risk for complication, cardiovascular, malignancy, and liver. Patients should be then stratified by non-invasive markers of fibrosis, which could be a first step FIB4 in primary care and FibroScan in tertiary care. Weight loss is the main treatment for the disease, and let's not forget the cardiovascular risk and the cancer screening on a regular basis in these patients. And also, we have a dedicated clinic in St. Mary's Hospital in clinical trial that we can offer to these patients. We are more than happy to discuss any case that you want to run through us. And thank you very much for your attention to the colleague I work with. Thank you very much.
Thank you, Roberta. That was a very, very comprehensive talk covering a large area of fatty liver disease in a short period of time. Really, really great. Thank you.
Thank you.
Now, questions from audience. I think we've got one from Harriet. Can FIB score be used in those aged less than 35?
Yes, this is actually a great question. So let's say first that FIB4 is actually now used in primary care, but was in the first place was derived from tertiary care population. So FIB4 actually it's very good at predicting the presence of fibrosis in those with abnormal LFTs and middle age, because it was derived from a population reflecting those characteristics. So from a study we have done in primary care, we have seen that FIB4 can underestimate in the presence of fibrosis in patients younger than 40. So it is still also because those patients have normal LFTs usually. So there is still a lot of work to do. And we know that unfortunately with current pathway, we might lose some patients with normal LFTs and a younger age, but it's still the best pathway we have at the moment. But we're working on that.
Thank you, Roberta. And can I just ask, the ELF blood panel, is that available in primary care?
So the ELF score is available in primary care. It's expensive because it's a kind of patented non-invasive marker. So I know that we know, because it's been extensively published, in the Camden and Islington area, there is the pathway for NAFLD includes either FIB4 or ELF, but this was because the liver service from Royal Free essentially got a kind of deal, and it reduced the cost of ELF for primary care. But otherwise, GPs are definitely more keen to calculate FIB4 because it has no cost compared to the ELF. So, but on the other side, the ELF is more accurate than the FIB4, even in primary care. So it's kind of it's a choice of the GPs actually, but they do tend to not request the ELF, although they can have access to it because it's expensive.
Thank you.
That's really helpful. Can I also ask a question, Roberta? There's a difference in reference ranges between male, female for ALT and AST. So when we calculate the FIB4 scores, do they take into account gender?
No, No, they do not. So even as you, of course, you will know, we have different cutoff even at Imperial College for ALT, not for AST, but yes, for ALT, probably because of muscle mass or anyway the differences in gender. But this is not taken into account in the FIB4, and this is another important limitation. And also, as I said, age has a very strong weight in that kind of equation. So this is the reason why FIB4 can overestimate severity of liver disease in those older than 60 and underestimates those on the other side in the young one.
Okay, that's really helpful. So maybe in the future, hopefully they can maybe adjust it and put the age and gender in.
Yes.
Julia's got a question.
I just want, hi, thank you for your talk. It was really, really lovely. I just wanted to ask you a question about, because sort of certain populations like patients with diabetes and obesity have such a high incidence of non-alcoholic fatty liver disease, and because LFTs are normal in such a large number, is there any point in doing the first few steps? Shouldn't they just all go straight for FibroScan in pre-specified populations?
I think they should do a FibroScan at least once in their life. So from the GP point of view, if it's a GP asking me, I would say do a FIB4 and then refer if a FIB4 greater than 1.3. But if the patient is already seen in tertiary care, we would say request a FibroScan straight away.
That's really helpful.
Yeah, thank you.
Okay. And one last question. How reversible is stage 3 fibrosis?
Stage 3 fibrosis is very reversible. Even we have evidence that with weight loss greater than 7%, greater than 7% for advanced fibrosis, which is stage 3, and greater than 10% for the early cirrhosis, they can actually regress, and slowly, because it's a very slow progressive disease, they can slowly go back to a practically normal liver. And we do see it with the bariatric surgery, actually, because these patients, sometimes they get you guys will know much better than me, sometimes they get diagnosed with cirrhosis while they do surgery. And then we follow them up, and after 1 year and a half or 2 years, their advanced fibrosis has totally been cleared because of the important and sudden weight loss. I mean, some of them may develop some negative consequences of this sudden weight loss, but the majority of patients do resolve their fibrosis. It's just amazing.
So you're saying, so even if they've got cirrhosis, that is potentially reversible?
Yes, early fibrosis, yes, before fibrosis gets into portal hypertension, because at that stage is almost irreversible. But the very early stages, yes, it can reverse.
Okay, that's amazing. Thank you. Okay, any other questions from anyone? Well, thank you everyone for joining. I hope that we've covered a broad range of topics today. And if you have any other questions at all, don't hesitate to get back in touch. I think the team, Wei and Mariana, has posted a link. That's the QR code, because if you can join this QR code, you can then give meeting feedback and also get your certificate. Okay.